let me just
Set up the
yes.
pop-up. Can you make it full screen?
I'll make it full screen. Okay, great. Is that better?
Yeah, great.
Okay, great. So, as you know, pneumoconiosis is a group of serious occupational diseases associated with the inhalation of mineral dust and corresponding reaction of the lung. So, this eventually induces irreversible lung damage that afflicts tens of millions of workers in hazardous occupations everywhere. In the United States, we have many, but we will get to some of the statistics. So, what kinds of pneumoconiosis are there? Well, there's the most famous ones: asbestosis, silicosis, coal miners' lung. Those are fibrotic, and then there's all sorts of other entities that also produce this. An interesting entity also is diacetyl, which is a compound that they used to use for popcorn here in the United States. And that caused, unfortunately, people to get pneumoconiosis. And then there's throughout the world, there's also interactions between inhalation of dust and tuberculosis, etc. And we'll go over some of those diseases, which have been known for like 100 years. Okay, so what are the statistics regarding uh, pneumoconiosis? Has it been increasing? And you can say that there has been increase according to the statistics from an international organization, international group. And according to this, has increased 81.1% from 1990 to 2017. So this is troublesome. And even here in the United States, I just saw a case come in earlier this month. So the patient had been working, I guess, forming like marble countertops, and he came in very, very sick. His lungs were infiltrated with these particles, etc., and the reaction that it caused. So this is a major occupational health illness in the world, and obviously it depends on what kinds of things are allowed in different countries. And as you can see here, unfavorable trend that asbestosis was predominant in countries with high socio-demographic index. For example, in Australia and New Zealand, they have a lot of people who come up with asbestosis. So exposure to silica puts one at risk for tuberculosis, cancer, and emphysema. Moving on here. So let's take a look at some of the worldwide statistics here. So as you can see here, this is again from that paper, the pneumoconiosis cases caused by different etiologies, and this is based on socio-demographic index globally, as you can see here, increasing from 1990 to now. There's a great increase in some of these diseases, including silicosis, asbestosis, co-workers, which has actually gone down in many countries because of the limitations in those kinds of jobs. So here's a map that I have found also in this, the global epidemic of pneumoconiosis. China has increased significantly in the number of cases that they've seen over the last 20 years. Of course, another country that has also increased is India, and the United States has also increased in that time. And in South Africa, one of the important things that you may consider is that there are people in the gold mines also have been having increased incidence of this disease. The asbestosis is seen in New Zealand and Spain. So as you can see here, a little map. Obviously, there's some countries where we don't see, or maybe they don't have the data for. Russia is very large, and as you can see there, we don't have any information on them. And this is just another chart demonstrating the incident cases of pneumoconiosis at the regional level. East Asia, Southeast Asia have also increased, and the other areas throughout the world have not increased as much. The left column on each group is case data from 1990, and the right column is data from 2017. So you can see that there is a little bit of increase, obviously, in 2017 as opposed to 1990. So here these are some of the common types of pneumoconiosis. As I mentioned, asbestosis, silicosis, coal miner's lung, beryllium, talc is also a big thing we see. Some of the other ones not as much, and of course pneumoconiosis associated with tuberculosis. So there are two types of pneumoconiosis. We have the fibrotic type, and I mentioned to you that there was silicosis, co-workers pneumoconiosis, asbestosis, borreliosis, and TALP. So different processes of what's going on in the lungs versus non-fibrotic, involving particle-laden macrophages with minimal or no fibrosis, siderosis, stenosis, and baritosis. And sometimes when you do upper GIs, you may use barium, and you do have to be a little bit worried about aspiration, but it doesn't mean that the patient's going to get fibrosis. A different type of reaction will occur. Okay, so I borrowed this from Dr. Naoki's paper, and it sort of says, what are the immune activities that are happening? As you can see here, it's a very complex chart, and obviously I don't understand much of it because it's all immunological, but this is something, a paper that you may refer to look at the exact immunological occurrences with the with cytokines and macrophages, et cetera, that occur in the inflammatory process going on in the lungs. Okay, so let's go on to silicosis. There are two types. There's acute versus classical. The acute silicosis occurs after a few months, usually from a few months to 2 or 3 years, and that is after exposure to high concentrations of silica. We also have something called alveolar silicoproteinosis. That's intense to coarse. That can happen very quickly in a few months, and no fibrosis, but it is often fatal, so you have to be careful about that. And the classical silicosis occurs after 15 to 20 years, and it's simple nodular silicosis, simple silicosis versus complicated silicosis, and large conglomerates of opacity. So that's after many years, 15, 20 years after the patient has already realized that he's having difficulty breathing, and maybe a diagnosis has been made, and the patient still continues to work without sufficient occupational preventative respiratory help. Okay, so let's just look at this. So this is a high resolution, this is acute. And as you can see on this high resolution CT, this demonstrates airspace consolidations here. And also there are innumerable ill-defined central lobular nodules. There's confluent nodules present along the right middle lobe, as you can see. And then there's also ground glass opacities and crazy paving, as you can see here on the bottom CT, with some peripheral sparing. This one is acute silicosis, may resemble primary alveolar proteinosis, and the reaction here is PAS positive lipoproteinaceous material filling the air spaces. So as you can see here, there's more consolidative opacities with air bronchograms in the bilateral lower lungs. There are also, as you can see here, foci of calcifications here in the left hilar area. Small bilateral pleural effusions, as you can see, very minimal. And the airspace consolidations. Okay, so now we move on to classical silicosis, and this, as I mentioned, occurs after 15 to 20 years. We have two different types of this classical. We have simple silicosis versus complicated silicosis. The simple is just nodular silicosis, and the complicated, large conglomeratous opacities, as you probably know, progressive massive fibrosis. I've seen a couple cases in our institution. And so this image shows what? Obtained with polarized light, shows these small little areas that appear different than the underlying lung. And these are shown with polarized light. So this is classic silicosis, simple, as you can see, nodular silicosis, many nodules in the upper lungs, throughout, everywhere, filling both lungs. And then we have the more famous type, or the one that I know people people see this and if they know the patient has silicosis, they may be able to determine right away that these are progressive massive fibrosis bands. Most of the time, and I've only seen them in the upper lungs. I don't think they occur in the lower lungs. That's a classic appearance of progressive massive fibrosis. Again, here you can see the progressive massive fibrosis with bands leading to the parenchymal distortion of the upper lobes. There's a lot of calcifications in this area. And another thing that we should also look out for is the paratracheal and hilar lymph nodes with central calcifications. And one of the things that we might call these eggshell calcifications, highly suggestive of silicosis. Here we have right-sided pleural thickening with all these nodularities, as you can see here. Another thing you may see with classical silicosis, not as frequently as with asbestosis, but you may see round atelectasis maybe. And that usually is more indicative of asbestosis, but it can occur with classical silicosis, complicated silicosis. Also, you're going to see a little bit of bronchiectasis here. You see on both sides, there's just a little bit mild bronchiectasis, but that is not pathognomonic for the disease. Now, sometimes what happens is you have also infections, tuberculosis, and this occurs with patients perhaps with silicosis. They get infected with tuberculosis, and now you have one infectious disease over the fibrotic disease of the lungs. And this occurs, this type of disease occurs 2.8 times more for men with silicosis than without silicosis. And again, there's nodules, consolidations, cavitations, and rapid disease. Cavitations can also be seen here, but you have to be careful that you realize that it's silicosis, tuberculosis, and not something else, caused by ischemic changes. Moving on to asbestosis. So I thought I'd show you this. You probably see these a lot, people working with these types of stones, and there's 6 naturally occurring silicate minerals from a mixture of calcium, magnesium, iron, sodium. And there's 2 types of groups, the serpentine, they're wave-like, and the amphilope, these are needle-shaped. And this is the type that leads to asbestosis. And there's amosite, crocodylite, which is blue asbestosis, tremolite, anthophyllite, actinolite, and erinonite. And for some reason, the very last one, erinonite, somehow is used here in the United States a lot, and that's a lot of the individuals who get asbestosis here have used that kind of stone. Going on to, there's asbestosis. So as you know, there's 2 types of, there's the benign pleural parenchymal lung disease, and then there's increase for malignancy for some people. Okay. Asbestosis-related benign pleural disease. So benign asbestosis-induced pleural effusions, which is usually exudative in 20%. There's pleural plaques. There's diffuse pleural thickening. Again, here you see round atelectasis and asbestosis. So these are all more, the first 4 are more having to do with the pleura, whereas asbestosis is more to do with the actual lung parenchyma. So I saw this very fantastic paper which shows diagrams, and this was part of the European Thoracic Society and Fleischner meeting from 2019, which shows you in cartoon form or in diagram form benign asbestosis-related pleural effusions, as you can see here, exudative. This can be the early presentation of asbestosis-related disease, and it can have some hemorrhage, and does not contain asbestos bodies, can coexist with benign asbestos-related disease, and diffuse pleural thickening, as you can see here around the perimeter of the right lung, This can develop after pleural effusion, especially in recurrent cases. Surrounds whole lung, including apices and costophrenic angles, high level irregularity, mediastinal localization, and interlobar fissuring, and thickening should raise the suspicion of malignant changes to come. So here we have the pleural plaques. Again, they're scattered bilaterally. These can be calcified or non-calcified, and depending on the age of the plaques, they're most frequently bilateral, usually occur in the parietal pleura. They're seen throughout the lungs, including pericostal, mediastinal, diaphragmatic, etc. And there may be some sparing of apices. They're more lower lung. Now, the rounded atelectasis, as you know, that's kind of pathognomonic for asbestosis. Round or oval-shaped mass adherent to the pleura with distortion of bronchovascular bundles and forming a sort of spiral type configuration. So let's take a look at some of these on CT. So we have some pleural thickening here with rounded atelectasis and hydrothorax in a patient with known asbestosis, as you can see here. So you have this round atelectasis, you have the pleural effusion, you have the swirling of the bronchovascular bundles, and so this person had asbestosis at higher risk for malignant transformation. And then there's asbestosis. So this is dose-dependent, developing after prolonged exposure to high doses of asbestos. Subpleural distribution starts at lower lobes again, can involve middle lobe and lingulum, or even upper lungs in advanced cases. So there's subpleural curvilinear lines, as you can see here, curvilinear lines. There's small subpleural nodules corresponding to peribronchial nodular fibrosis, nodules here. Fibrotic bands, as you can see here, they're kind of spiculated areas here adjacent to the pleura. There's pleural-based intralobular septal thickening. There can be even honeycombing and traction bronchiectasis in very advanced stages. Honeycombing here. So thickening interlobar septa and traction bronchiectasis, as you can see here. And ground glass may be a sign of fine fibrosis. Okay. This is from another paper. So as I had mentioned to you, these hairy pleural plaques with some of these spiculated areas. There's a pleural effusions, the exudative. There's asbestos-related fibrosis along the edge with calcifications, and there's round atelectasis. And as you can see here, these are very linear type foreign bodies within the lungs implant and then start the inflammatory reaction. And another differential that you can maybe consider is UIP in this type of disease. Okay, so this is progressive asbestosis in a gentleman or in a patient who was 76-year-old, patient with known asbestos exposure. And most of the patients obviously will be men because those are the jobs most commonly associated with men are more ship workers or cutting different types of material that will emit dust, which then will be inhaled by these patients. So 3 years later, as you can see, there's increased. One of the important things is that even though at the very beginning there was just a little bit of honeycombing, the honeycombing has extended and become much more severe. Okay, so what about asbestos-related other disease, malignancy? Bronchogenic carcinoma is one thing. The more famous one is mesothelioma. And other entities such as renal cell carcinoma, laryngeal carcinoma, and gastrointestinal tumor. Obviously, we're not going to go over the other ones as much as the first top two. So in mesothelioma, we'll see pleural mesothelioma, which is 90%. Much less is peritoneal mesothelioma, which does occur. Pericardial mesothelioma, which we see very infrequently, and cystic and multicystic mesothelioma, and kind of tunic vaginalis testis mesothelioma, which I've never seen but is in the literature. So the malignant types are three histological types. There's epithelial, which is the majority of 60%, the mix, and there's sarcomatous, which is the least um, histological type. So let's take a look here at this, again, another diagram from the European Thoracic Society. So there's pleural thickening, which can be smooth or irregular. Masses involvement of the interlobular fissures and mediastinal surface, as you can see here. Pleural effusions, they can be loculated. Pleural plaques, maybe here we don't have a picture, but it could be with calcifications. In advanced disease, the lung becomes retracted with reduced volume and very likely to invade adjacent structures, lung parenchyma, chest wall, mediastinum, pericardium, contralateral pleura, in fact, the diaphragm, and then extend into the abdominal organs and peritoneum. So this is a picture of mesothelioma that I found, and as you can see here, there is diffuse left-sided pleural thickening. There is maybe a very tiny, small pneumothorax, which is up here. And there's fibrotic changes in the left hemithorax, demonstrating this very thick calcified pleural mass expanding to the fissure and sort of abutting the aorta and endothoracic fascia. Okay, so this is something that looks like that. And here on PET-CT, you can see here that the lining is all FDG positive. The disease is very bad. Not sure how they treat this, but a lot of times these patients are very sick and, may not be able to be treated at this point because of this invasive process. Another thing, and just very briefly, malignant peritoneal mesothelioma, just to cover it just really quickly, we have tri-painful type, which is peritoneal masses with no ascites. There's the wet type, which is ascites with masses, the mixed type, both pain and ascites. And again, there's three histological types, epithelial at 80%, sarcomatous 10%, and mixed 10%. And we do occasionally see patients with peritoneal mesothelioma, but again, that's very rare in our population. Co-workers pneumoconiosis, these are not these do progress, but they're not as extensive as silicosis or asbestosis. They're small, rounded, reticular nodules, as you can see here, and the more complicated is large opacities, similar to progressive massive fibrosis. So the way that we would figure out, well, how is this silicosis versus co-workers pneumoconiosis? That's the history of the patient. In other countries, co-workers pneumoconiosis is more it is larger in number than silicosis, whereas in the United States it's more silicosis, and worldwide as well. More silicosis cases are what would cause the progressive massive fibrosis. So there's a simple round reticular and reticular nodule opacity, as you can see, small. You can see the lungs are not really affected that much in this particular patient, but then you get the massive or the progressive massive fibrosis, which is seen here. And there's small little pleural thickenings here. Calcification is not usually a component of this particular disease. And this is just from an article that I got just to show you what happens in this radiograph and also the histological appearance of what we see. This gentleman underwent bilateral lung transplant at the age of 60. So he had 35 years of coal mining experience, and he had no history of smoking. And after 24 years of coal mine employment, showing category 3 pneumoconiosis and with Q and R type opacities, and that is according to the grading system and we will get to that later on in the lecture about the very complex um, grading systems that they have for these diseases. So after 32 years and 35 years of coal mining employment, as you can see here, he definitely has more of these small nodularities, mass-like lesions and nodules enlarged as time progressed. And here you can see the specimen, his lung here. You can see how destructive the upper lobe of the lung has become. All these very invasive areas um, have been replaced by progressive massive fibrosis here at the superior lungs and nodular lesions, as you can see here. Also, these give rise to lung cancer, as you can see here. The interesting thing about this, even though it's very rounded, there's spiculated margins, more consistent with malignancy. Let's take a look at this bilateral mediastinal and hilar lymph nodes enlargement. They're small nodulars along the bronchovascular bundles and subpleural fissures here, as you can see. And this is berylliosis. And many of these diseases react the same. So the lymph nodes are more consistent with silicosis, and some of these small little nodules are maybe seen with asbestosis or even coworkers. So there's a combination of reactions here in some of these. Now there is an entity which I've never seen called giant cell interstitial pneumonia, and this pulmonary fibrosis is caused by exposure to metal compounds such as cobalt, tungsten, carbide, very infiltrative type disease, and some maybe a little bit of honeycombing at the bottom here throughout the lung. Talcosis is dense consolidations with dilated bronchi and emphysematous ground glass opacities here at the bottom, and interlobar septal thickening, as you can see here, all throughout the bilateral lungs. So this is something, I don't know if here in the United States, unfortunately, we have a lot of people who there's a lot of people who take drugs, and this was via injection of talc-containing methylphenidate, called Ritalin drug. So I guess they use talc to sort of mix the Ritalin, and then they inject this. I've never seen a case like this. We do sometimes see people who inhale different drugs, but this is something maybe that you should be aware of. Okay, so now we go into the non-fibrotic. These are less serious, but still very problematic, and some patients we do see in certain areas of the United States involve particle-laden macrophages with minimal or no fibrosis, the siderosis, stenosis, baritosis. And the baritosis is usually seen with maybe people who have inhaled a lot of barium during procedures. So as you can see here on siderosis, multiple small centrolobular nodules of the upper lobes, very small areas here, very faint areas. You might even consider that maybe the patient has maybe some inflammatory change, non-specific, maybe hypersensitive pneumonitis very early. Here, this is much more advanced disease of stenosis. The tin oxide is deposited in the lung tissue after inhalation. These are extremely visible, and there is a extreme dense, although there is no tissue reaction yet on this scan. And this is a high resolution of the CT, reticular nodular infiltrative areas, diffuse nodulations, peribronchial thickening, and ill-defined areas of ground glass opacities, as you can see. Now, this one is baritosis, benign non-fibrotic pneumoconiosis, which can be precipitated by aspiration of barium. Inhaled barium particles can lie in the lungs for years without producing symptoms or causing any impairment in lung function. Again, as you can see here, this patient has large amount of keratosis. I don't know if this was from a procedure that he had, but as you can see, very involved bilateral movements. Now, a disease that you may not have seen is Kaplan's syndrome. Now, this is a combination of pneumoconiosis with rheumatoid arthritis, and this combination then produces this syndrome, Kaplan's syndrome, necrobiotic nodules, and when there used to be a lot of co-workers in Wales, some patients with rheumatoid arthritis showed up with this syndrome. It's called like the synnervation of necrophages in the lymphoid. It's really pigmented bloodstreams and fibrosis. So that I mentioned to you before is the International Labor Organization, ILO. They have a classification system for many of these pneumoconiosis, etc. They've standardized after many years how to read these radiographs, and there are actually courses in the United States, and I don't know if they have online courses for this, but they actually have individuals who are trained to just look at the x-rays so that they can ensure that the patient is getting the best read possible for on a radiogram. So what they've standardized is when to call small rounded opacities, and the patient is known to have these exposures, small irregular opacities, profusion of opacities, large opacities, zonal distribution of opacities, and pleural thickening. And let's just go on to the next slide here. The grading system that they use is 0, no lung abnormalities, mild, with mild pneumoconiosis appearance, moderate pneumoconiosis, and 3 severe interstitial lung disease having appearance of severe pneumoconiosis. So it's very complex, and I'm only going to show you just a few diagrams that I was able to find. The training program has many, I don't know, maybe 50 or so diagrams that evaluate the disease process. In this one, this is just asbestos causing pleural changes. We have chest wall fat, extrapleural fatty deposits mimicking plaques, and more severe seen on the second diagram. Then we have chest wall plaquing, which is slightly different than the other two because those are more fat containing. We have in profile, we have NFOS, pleural thickening, and pleural plaques. We have pleural effusions, mesothelioma here, as you can see, is more along the lower lung base. We have fissural, visceral plaques, and other small changes that can occur with asbestosis causing pleural changes. This is pleural disease classification here.
Martha, sorry to interrupt you. The voice is slightly breaking.
I was just.
Maybe you can try switching off your video and then speaking. That might help. Can you hear us, Martha? Can you hear us, Martha? We can see your slides, but we can't hear you.
Can you hear me now?
Yes, now it's clear.
Okay, sorry about that. I don't know what happened. Sometimes we have issues, and we've had unfortunately a big internet problem
Yeah,
in the United States.
it's there across the world. Don't worry. We've all
Anyway,
experienced that.
they had to shut down some of the airports.
Yeah, yeah, yeah. There were a lot of delays in the flights, etc. But
All
thankfully,
right,
we can hear
so
you.
sorry about that. And what I just wanted to show you is that there's a lot of work been going on for hundreds of years with the International Labor Organization, and so they have a standardized system.
Full screen again.
Oh, sorry, hold on just a second. Let me see if I can get there. Okay. Yeah, sorry.
Perfect.
So basically, there are courses, and I went through this just, with a grading system 1, 2, 3, and some of the charts that have been produced by ILO, and there are individuals who are trained to look at this, and they basically work as consultants for different government organizations here in the United States. OSHA is one of them, but they actually grade these according to all these different entities that they look at. This is just for asbestos causing pleural changes and mesothelioma. And this is just pleural disease classifications, depending on the thickness as well. We do have individuals, I think they're called B readers here in the United States, um, but they actually look at this and grade each and every plaque, I believe, or extent of the thickness of each pleural disease. And here we have, let me see, this one was, I have to go down. Oh, yeah, this is silicosis. Sorry. Let me get back. Silicosis and co-worker pneumoconiosis, the amount of pleural scarring, as you can see here, they grade them on the same level. So usually it starts off, it's really upper lung. Then you start having the progressive massive fibrosis here at the top. And as you can see, their silicosis and co-workers are graded very similar, so they put them on the same charts to look at. And Dr. Powers has a course, I believe, in which he trains people to read these types of x-rays. And okay, so again, the treatment, no treatment is known to reverse the damage. As you note, there was that gentleman who had the co-worker who had bilateral lung transplants. I think that's really the only treatment that will help the patient completely resolve the disease. But usually it's no treatment. Many of these patients also get other diseases, maybe they're smokers, that impacts the emphysematous changes that you may see. There's a pulmonary rehabilitation, which may help the patient. And basically, it's to try to maintain a healthy lifestyle without being involved in breathing in these particles to stop the progression of the disease. So basically, be vigilant about development of infections, because that obviously will affect the patient, make them much sicker. The tuberculosis on top of the pneumoconiosis can be extremely damaging for the patient. Oh, and I did come across this. I'm a little bit late because it's the 21st, but you did have Happy Doctor's Day on July the 1st. And I hope you all had a good day. And anyway, I guess we're open for questions. Here, let me stop sharing.
Yeah, thanks a lot. So, there are a couple of questions on the Q&A.
Mm-hmm.
The first one by an anonymous attendee is essentially asking, if we don't have the history of exposure or occupational history,
Mm-hmm.
and we just see these findings, how do we narrow it down to, this differential? If
Yeah,
is it,
and you know what?
when do you
Yeah,
think?
that's very, very hard. So number one is, let's see, if you see the fibrotic bands, how do you describe them and report this on clinical history? I think you can just be general about it And you can suggest, I don't know, maybe in some areas, like I'm in Chicago, but I know that there are people who like are out east or west who maybe might have individuals who are more involved with shipbuilding. So they're going to see it at a much higher rate. Like, so I probably will not put that in the differential, but those individuals who live in these other states where there's much more industry of this type might say, "Oh, I remember seeing this," and I would, I would would say that this isn't differential. Now, another thing too is here we have a lot of what is it called, multidisciplinary teams who present something where they're not really sure what's going on with the patient, and obviously, we have the primary care doctor, the radiologist, the oncologist, or whoever, the pulmonologist. So the pulmonologist would probably be the person who would have a more accurate history. And so it's sort of like sharing of information. If you don't know, just describe it generally. And and obviously, some of these diseases might just be other types of interstitial lung disease. So it's a matter of just looking at the findings and then saying it could be this differential, something else. If obviously if the patient's a man, it might increase the risk of or put that differential higher up on the list. Okay, how differentiate between lung cancer opacity and massive? Okay, so that again is difficult because obviously you see that even if you do PET CT, so eventually um, progressive massive fibrosis is usually bilateral. Um, if you see bilateral um, entities or consolidative opacities like that, which with traction bronchiectasis, and it looks symmetrical, then that points to um, massive progressive fibrosis versus versus cancer, because even on PET CT, you would probably um, have uptake bilaterally. Now, the only other way that would help you figure out what's going on is biopsy. And then you would see that, oh, these are all just immunological changes. They're not, it's not adenocarcinoma, et cetera, or, squamous cell or whatever. So eventually, if you see symmetry, then you would say, well, it seems like they're symmetrical. It seems like it's more environmentally um, a disease than it is a cancer. How often do you perform follow-up with high resolution CT? Here we do use some high resolution. Usually it's at the beginning. So if you need to find out is there honeycombing, etc., one would be sufficient at the beginning of the course baseline. If you wanted to follow them with high resolution, you could also do that. Usually you don't need more than the first one, the baseline, and then you can follow them with just general. Which of these is the worst in terms of prognosis? Well, number one is silicosis is seen here more than asbestosis, but asbestosis has the characteristic of progressing to mesothelioma. And in fact, in the United States, there is a big fund that was made by the Congress of the United States. I don't know how much money they put into it, but sometimes you hear on the radio, if you think that you were at risk for mesothelioma, et cetera, there are a lot of attorneys who are involved in educating the public about mesothelioma because they can then go to this fund and ask for money, and then they would get compensated for their time in bringing these patients to the to the forefront and getting what they deserve for this mesothelioma. Which of okay, so I would say asbestosis may be worse because it increases your risk of mesothelioma. Um, how to differentiate TB nodules, isolated superadded from simple? Okay, well, I think the only way that you can really figure out is if you know the patient is at risk for TB, and there's really no way to really distinguish them other than that patient is also in this type of industry where they will have be exposed to silicosis. So it could be either or it could be combined. You never know because TB obviously works in synchrony or some sort of symbiosis with the fibrotic diseases. So it's very difficult to tell without histology. So you'd have to really go to histology, or the patient had TB, or the patient started working with silico and then became infected with TB. That would be the only way that you could know that there's probably some sort of um, both maybe present. Okay, requires confirmation by lung biopsy, overlapping and coexisting. Well, not necessarily lung biopsy, but if you know the patient is at risk for TB, you may, number one is history is everything. So if the patient has history of silicosis, number one, and then they have combined TB, then you know that this could be problematic because you're going to have a hard time figuring out which nodule is what. So it could be both together. Um, okay, so PF massive. Let's go back to. Oh, sorry. Let me go back to. So as I had mentioned before, that if someone has silicosis, they have a 2.8 times increased risk of getting tuberculosis or having tuberculosis progress. Here, for example, if you didn't know the patient had had silicosis, it would be very difficult because you'd think, well, this patient has TB. I think if the patient has both, then you could make the suspicion that the patient has silicotuberculosis. Um, but it's about history. It's not necessarily how you distinguish based on imaging if there's a complicated case. Okay. Yeah. All right. So yeah, you may have to do the lung biopsy, but it's basically history. And I apologize for that. Okay. Overlapping or code. It says if there's any biopsy for determining exposure of relative, should we advise in such cases? Well, number one is, so if a patient has, for example, we're talking about in case of conspicuous history, okay, if you know kind of the history, then you should advise that this may be environmentally related. So that's number one. So if the patient has other things, if there's other risks like tuberculosis, you may have to say, well, this is maybe one on top of the other. So I would leave biopsy for people who have like after you've done the PET CT and you have questions about whether or not this could be a lung cancer, then you may suggest that they go for biopsy. But that's after having a very detailed history of the patient, his exposures to his family, etc. Um, how do you differentiate fibrotic versus atelectic bands? So let's take a look at that. Fibrotic versus atelectic. So here, this is, as you know, the round atelectasis. This one is classical, it's mnemonic, but the other ones may not necessarily, like for example, if you have small areas where you have bands, um, it's very difficult to tell other than you have a history of, the history of the patient exposure, like here, fibrotic bands. So these are much more like, as I want to say to you, they're kind of like prickly. They're more spiculated, and I think there's another one here. fibrotic bands here, as you can see, they kind of are like linear. They look like they're emanating, like they look like maybe caterpillar legs more so. Whereas atelectasis, so you see how they protrude out from the pleura. Atelectasis, I think, is more linear around the posterior lungs. This is more, could be anywhere in the pleura. And so that's how I would say you might be able to distinguish them. Number three, again, you have fibrotic bands. You see how they're long and thin, whereas many of the atelectic areas are more linear versus these are linear protruding out versus the other linearity protruding across horizontal. What should be the follow-up imaging recommended suggest for pneumoconiosis? Um, I would suggest initially maybe a baseline, and then obviously you would want to treat the patient to reduce the risk of progression, infection, etc. And you could do it maybe every on an annual basis to begin with to see how they're progressing. But unfortunately, if there's no way to treat them, then you would just be following the progression. So you want to make sure that you're treating them, that you're minimizing the risk, and that I would say at a yearly level, you could do an X-ray, not necessarily a CT, but you maybe want to do one baseline CT to begin with. Um, let's see. In low dose CT, what is the mini dose radiation to adults and child? Um, I'm not sure about that question. What is the mini radiation dose to adults versus child? Well, obviously in children, usually we don't like to do CTs on children unless it's absolutely necessary. So I would say don't do any chest CTs for children unless you absolutely have to, and those should be a very low radiation dose and should not be repeated. Adults, again, sometimes you have to be very careful that adults do not receive CTs or too many of them. If for this type of disease, you might want to do a high resolution CT as baseline and then maybe follow up as symptoms worsen, etc. But you have to be very careful about the amount of dose. And in some hospitals, they actually do they maintain a record, a registry of everyone's radiation dose to ensure that the patient is not being overly radiated by just, the medical. Silicosis versus sarcoidosis. Okay, that's a very interesting thought. Sarcoid. So number one is, and I'm going to ask you a question now, is how, what is the sort of like the individuals who have sarcoid in your population? Is it more in particular areas or not?
Sarcoid is, uh, I would say, I think the gender is one thing, the history, and of course, there's no occupational history, so I think that helps out.
Yeah.
Overall, of
Yeah.
course, I think we see more sarcoid than silicosis in India.
But like here for example, in the United States, like the classic patient with sarcoid is going to be, middle-aged African American lady. Whereas in Finland, it might, it's an older white guy or something like that, an older guy who's nothing. So I'm just trying to figure out maybe the type of person that gets sarcoid in your population, who gets sarcoid more?
Yeah, so it's more like to be likely to be a middle-aged lady, often even a male, but more commonly in the middle ages.
Yeah. And I would say that's very difficult, but you point to the exact thing as history. So if it's a woman, most likely she's not going to have silicosis because most of the people in our population who get these types of diseases are men because that's the kind of work they do. So it'd be very difficult. I mean, obviously, sometimes men can come home and they have particles on their clothes and they will then take it home. And so that's problematic. But usually it's not going to be women. Usually it's not going to get women with silicosis, and usually men in our populations don't get sarcoid. It's usually females, but that, as obviously it's not a, you know, you have to allow for differences, etc. And also, and I'm not sure whether you've heard this, but is it sarcoid maybe immunological reaction to maybe to trees or something, to the environment, the trees in your area? Could that be a possibility?
I think that would be less common. So it is some autoimmune process. I'm not sure whether it is proven to be related to something like that. But
Yeah, and
you
yeah, and
talk.
we and here at the university we have how do I want to say this? We have a center. It was named after a gentleman who was what do they call it? He was an actor and he got sarcoid. He died of sarcoid. And one of the things is sarcoid is what? Sarcoid invades what other organs most significantly? And that would be the heart. So I'm not saying you have to look at their heart and do like a delayed MRI to figure out are there are there plaques in the heart, and then that would lead you more towards sarcoid. But that is a test that is done here, and obviously they do nuclear medicine cardiac studies as well. But the sarcoid versus silicosis would have to be history, number one, and just sort of like the person, the individual, like what is the suspected risk of having been involved in that kind of work. Now, this is very interesting, this
I can
antifibrotic
just
drug.
add one thing, Martha. So I remember one case we had when I was doing my residency, and so one place where I think women get exposed to silica in India is flour
Yes,
mills, the atta chakkis, because there are some places with flour mills and having specific machinery which does expose
yes.
silica. So that is one history which we have observed in women who have got silicosis, just for the audience.
Okay, great. Yeah, so that's very interesting. Um, Obviously there's a lot of like as I was mentioning to you, this the popcorn drug, the popcorn infiltration diacetyl. That also there were a lot of women working in that, and they got infected, or not infected, but they got exposed to that. Um, Now I find this very interesting. Antifibrotic drugs used in pneumoconiosis related uh, PMF. So there is, and I just put in the chat here, two drugs that are FDA approved for treatment of idiopathic fibrosis. Now, I don't know if they use these drugs specifically. In our population here at our hospital, we don't have a lot of fibrotic patients, but these drugs passed FDA approval. These are nintedanib and pirfenidone. Um, and slow down the rate of fibrosis or scarring in the lungs. But this is more for IPF. I don't know if they're used for other conditions, maybe for. I have to check into that. I don't know if that's used for pneumoconiosis or not. I'd have to look into that. Unfortunately, we don't get too many patients. We're not a center where a lot of these patients get sent to us. So I have not seen this used. They usually be in a clinical trial. Anyway, when you say a fibrosis as, I'm not sure what that means. Let's go here.
I think what she's asking is when would you just call it fibrosis and when will you call it PMF when you see fibrotic changes?
Okay, so PMF is what? It's specifically, it's more, and I got to say this because I have not really seen it. It's upper lung predominant, um, consolidative opacities with traction bronchiectasis and distortion of the upper lungs. That's when you use it. Whereas fibrosis is more, actually, to tell you the truth, it can be seen anywhere in the lungs, maybe even in the lower lungs. So this is a good picture. This is another good picture. Usually upper lobe predominant, complicated conglomerate opacities. And another thing is this can be seen with silicosis as well as co-workers disease, pneumoconiosis.
Wow. So that I think answers all the Q&A, and there were at least 15 on the Q&A box. So thank you so much, Martha. This was a wonderful
Well, thank you
session.
very much. And what I will do is I will send you a copy of the the paper or the ACR lung cancer incidental